Hello, I'm Dr. Jon Perlin. I'd like to welcome you to the first edition of A Physician's Lens. It's a CMO podcast that will be offered periodically to bring the HCA clinical community up to date on matters of importance. And right now, there's probably no matter of greater importance than, of course, the COVID pandemic. Very pleased today to have with me Dr. Ken Sands. Dr. Sands is our Chief Epidemiologist and Chief Patient Safety Officer. We stole him about 3 years ago from the Harvard system. He's been a great addition. He was looking for something really big to get involved with. And Ken, I think you've had that opportunity. Welcome.
Yes, thank you for providing me this opportunity. It's been really a wild ride these last few weeks.
Yeah, yes, it has. We're so glad to have you here, and your guidance has been absolutely instrumental. In fact, today, what we really want to do is steer our clinical colleagues to some of the guidance that's available in the areas of testing, therapy, and prevention. Prevention is really one of the most important things, so let's start with that. You'll probably notice that Ken and I are an appropriate 6+ feet apart this morning for our conversation, modeling what we hope to be really the norm across the HCA community where possible, but also the reason that we went to the concept of universal protection, because we know that as clinicians, sometimes we're in close quarters. So Ken, maybe start by talking a little bit about protection and prevention in the healthcare workplace.
Sure, we've really moved to a concept of universal protection, which recognizes the fact that COVID is going to be with us for some time, and there's no perfect test. I think we're going to talk about testing a little bit as well, but there's no real perfect test for identifying who has COVID and who's had COVID. And so universal protection becomes a really important concept. And so we expect our facilities to continue to be offering services in a way that provides that universal protection, which includes the universal masking that's been in place in our facilities for quite some time, the access control that we are doing at all the entrances to our facilities at this point, the social distancing that we've been practicing at home ends up being important in the facilities as well. And then working out workflows for all our patients, the COVID patients, the non-COVID patients, so that those populations remain separated from each other.
So Ken, you had mentioned the importance of masking everybody. One of the questions we frequently get is what kind of mask should different individuals in the healthcare environment be wearing?
Right, and the mask that people that are coming into the facility should be wearing is that simple mask. Could be a cloth mask, or what we have our employees wear is referred to as a level 1 mask. What we're really trying to do is create source control predominantly for people that may have infection with COVID but don't know it yet, they're not showing symptoms yet. We want to control any respiratory secretions that they may be generating. At the same time, those simple masks can prevent a certain amount of exposure from individuals that may come in contact with that people. So it really requires a simple mask. We provide masks for our employees, for visitors. They can be wearing their own mask that they bring, or we can provide them with a mask when they enter.
That's great, because people always forget about the source control that is really so important in breaking that cycle of transmission. We think about the protection, so critically important, but we have an opportunity there. And there's detailed guidance on our Atlas website in terms of the types of masks for aerosolizing procedures and other situations where there's a much higher risk of exposure. The other area that we want to move to is testing, and we know this creates a lot of confusion, quite frankly. We have really 3 flavors of testing. We have testing for the virus, which is typically done by amplification of the RNA by PCR. We have the antibody, or the blood or serology test that tells us if we had an exposure, and there's promise of a new antigen test, which picks up a protein from a sample of a respiratory secretion as well. Maybe, Ken, you could talk a little bit about the appropriate uses of these and the limitations in terms of interpretation.
Sure, and as clinicians know, there's no perfect test. Everything has some degree of limitations in terms of sensitivity and specificity. The RNA test that you mentioned, the test for whether someone has COVID disease, is a very sensitive test. However, getting a solid specimen can be difficult, and that can be a source of false negative tests. So a positive means positive. A negative in a situation where you are highly suspicious of the disease, it can be worth retesting because of the possibility of a false negative. So that's really the PCR. The other thing to know about the PCR RNA test is that it can remain positive for extended periods even after someone recovers from illness. And it is believed that that represents not continuous active infection or transmissibility, but rather remaining viral fragments that don't really represent transmission. So a positive test well into or well past the period of clinical illness probably does not represent transmissibility, and that's a point of confusion. The next category you mentioned is the serology testing, which is to see if someone has had the virus. And those tests, there's multiple versions that have been released on the market. Those have an issue in terms of false positives. So it is not clear that everybody who tests positive actually has had exposure to COVID. And so that has limited our enthusiasm for using those for individual patient management. They can be an issue for understanding population prevalence for public health purposes, and that's the current application. The third version you mentioned is the antigen tests, which would be an early, simple test for having the virus. So instead of having to amplify RNA, you're looking for an antigen. That would be still a respiratory swab, but could be resulted very quickly in a format similar to a pregnancy test. There are some versions of that that look promising, but are not quite yet on the market.
Well, that's great. So just to summarize, for the viral test, the PCR, in the context of a suspicious patient, positive means positive, but negative is not necessarily negative. As that person is convalescing, we worry about false positives due to remaining viral fragments. Okay.
Correct.
Moving on to the antibody test, that will tell us population prevalence, but there's a risk of false positives because of cross-reaction with other coronavirus. And then finally, we hope that there is a broadly available, easy-to-do pregnancy test like antigen test that can test a respiratory sample and be developed, if you will, very quickly, as that would really help us with a lot of the population dynamics of quarantining at risk, isolating the sick, and allowing others to get back to work. So this is the state of testing right now, and our hopes are that testing is more broadly available for all of the obvious reasons and such an important determinant in our clinical environment.
Exactly.
Let's talk a little bit about therapy. We've seen hopes for some drugs touted and dashed, hydroxychloroquine, for example, and some promise in other areas, such as remdesivir. I know we don't have time for an exhaustive review of the therapy, but you and the team have created some terrific resources. So maybe just a couple of highlights and some instruction on where we can get the detailed information on current therapeutics.
Yeah, we should point out that HCA has spent an enormous amount of time creating guidance and making sure that that guidance is up to date as possible. So if you go to our Atlas website and simply search for COVID treatment or COVID pharmacy, you will come up with our updated treatment guidance. It gets updated probably about every week and includes everything about both experimental therapies and those that are coming into actual more solid utilization. And we use our own experts within HCA to review these guidance and make sure that we have agreement. There's still a lot of debate about best practices. Hydroxychloroquine was popular, as we know. The data is increasingly showing limited to no benefit from either hydroxychloroquine or that combination with azithromycin. So that seems to be losing some popularity. At the same time, we have seen remdesivir release some studies showing that it shortens the course of illness, and that looks promising. HCA Hospitals has been one of the more significant contributors to the data set on remdesivir, since many of our hospitals have been part of the expanded access protocol for that drug. Now we are increasingly looking at convalescent plasma, and similarly we have registered almost all our hospitals that would qualify as expanded access sites so that we all can be participating in learning about convalescent plasma as another promising option.
Well, that's great information. I'm so proud of all of our colleagues who are doing that research. You know, really, the research through the HCA Research Institute, a subsidiary of our Sarah Cannon Research Institute, but really across all of our service lines are doing research in areas ranging from prevention to epidemiology to diagnosis, different modalities of testing, to a variety of therapies. And we have not only the opportunity, but I think the obligation to contribute to the rapid learning. And maybe that's the note on which to close this first conversation. I want to thank you very much, Dr. Sands, for your terrific leadership, the leadership of your team. But I think both of us really want to thank all of you, our fellow clinicians, who are there at the very front lines of care. We know that these are tough times for you and your family. We know that your communities are very different. We know that your kids aren't in school. We know that you're worried about your parents. And we know that you continue to come to work to serve the patients that are really the privilege of our mission, the care and improvement of human life. Thanks for joining us today. I promise future episodes will probably be shorter, but this is such a hot topic. We wanted to really give you a sense of that. Please, as always, feel free to contact your facility, chief medical officers. We look forward to working more closely with our medical executive committee leadership, your division chief medical officers, and your team here in Nashville is here to serve you. Thanks for everything that you do.